Hello and welcome to webinar number 8 in our AFBSS webinar series. Today's topic is open access clinic models. Now, without further ado, I'd love to present it over to our speakers, Amy and Greg.
I'm Amy Moulin. I'm an emergency medicine and addiction medicine physician here in Sacramento, California. And I'm also co-founder and principal investigator of our California Bridge program, which was really dedicated to providing access to treatment for people with substance use disorders. And I'm going to turn it off to my colleague, Greg.
Thank you, Amy, and thank you everyone for being here. Greg Vaishon. I'm a physician, internal medicine. I'm a principal in HMA's Chicago office. I've been with HMA 18 years. At HMA, I do a lot of work in ambulatory care medicine, so both primary and specialty care, a lot with operations and data and IT systems to succeed in population health. My clinical background, I was with Cook County Health as a medical director in the ambulatory care system, and then 10 years at an FQHC. And then I started a practice for primary care for people with substance use disorder to really prove out a model of contingency management. So that was my last clinical experience, and wrestled with open access there and making it financially viable. Thank you all. And Amy.
Okay, we'll go on to the next slide. So this is what we're going to talk about today, is really digging into open access clinics. We're going to talk about what is an open access clinic, the different spectrums of open access clinic models out there so you can think about what works best for your community. We're going to talk about metrics. So how do you know if you're succeeding with your open access clinic, and what are your goals that you should be working towards? We're going to talk about specific strategies for both implementing your open access clinic and also keeping that clinic open and making it financially sustainable. And hopefully we will have plenty of time for questions, answers. My goal for you is to really feel like you are ready to launch and sustain your open access clinic after this webinar. So we got a lot to do today. Next slide. These are going to be our learning objectives. So these are the things that our goals for you today will be: to describe at least 3 clinical benefits, I think there's more, of a low barrier open access clinic. You're going to identify at least 2 of the accountability metrics so that you can measure success for your clinic, as well as meeting the Medi-Cal managed care accountability set. We're going to list 3 strategies that address barriers to implementing low barrier open access care for people with substance use disorders, and list at least 2 strategies to sustain your open access clinic. Next slide. So this part, I just kind of want to give an overview of open access clinics, what they are and what they mean, so you can kind of understand like how you can start to implement one of these in your community. Next slide. This is where we are today. So we talk a lot about opioid use disorder and overdose, and I think that's because that is the most dramatic outcome of our lack of access. But really what we see is very much a systematic lack of access to care for people with substance use disorders. So this is data from California that looks about the number of people who are using all substances: alcohol, alcohol use disorder, cannabis, tobacco products. These are all widely prevalent in our community, but still there is a huge treatment gap. So if you looked at specifically to California, and these are just really the people that we have diagnosed. So we actually assume there's more than this number, but it says 6.1 million Californians were diagnosed as needing substance use treatment, and we only provided care to 1.2 million. So we're failing at a pretty spectacular level. 83% of people who need care, and those are the folks that we've recognized, there's probably more out there that we haven't even identified, got nothing. They're going without treatment. So, if you want to take a glass half full perspective is there's a lot of room for improvement. So we can do a lot better than we are right now, because our system right now we know is not meeting the needs of our community. Next slide. So today we're talking about specifically where we are today is the Behavioral Health Services Act. This is the part, what we're focusing in today is that piece around assertive field-based programs. And one of those pieces that we're going to dig in today is on open access clinics. For those of you who are at our recent regional workshop, some of the slides will be a little bit familiar, but we're really going to dig in today on open access clinics and what they mean and how to get them open in your communities. Next slide. So this is really what we want to talk about is these open access clinics and to think about, a broad view of where you can provide that open access to treatment for substance use disorders. And a lot of times when we think about a clinic, we think about our brick and mortar existing programs. Those are important, and you can leverage your existing clinic. We're going to talk about that, but also thinking about broadly where else you could embed open access clinic models. And that can be in syringe programs, medication units, drop-in clinics. So kind of think broadly about where this can live in your community. Next slide. This is really how SAMHSA defined low barrier care. And really the focus here is on flexibility and thinking about patient-centered goals and patient-centered care. So a lot of this is around what are the patient's goals. So meeting the patient's individual recovery goals are prioritized rather than the traditional goal of you have to be absent on day one, right? We know that that part is a long-term goal. And so recognizing what are the individual goals for the patient and how can we meet them. So a flexibility in our approach and recognizing that harm reduction, reduced use, engaging in less risky use, these can be acceptable interim goals. And we are not going to get to the final piece on day one. And then flexibility in how we're providing care and meeting people where they are. So flexibility in scheduling, in extended hours, in telehealth. So these are really the features of low barrier care that we're going to talk about for our open access clinics. Next slide. And this is really key, is thinking about how we take that flexible theory and build it into praxis. And one of the key pieces is around not making sure that people have preconditions before we provide care. We want to get to a point where we have reduced all friction between someone wanting help and someone receiving help. And so some of that traditional treatment structures ask people to do the hard part first. And we want to eliminate all barriers and we will get to the hard part later. And so we want to make sure that we are meeting people where they are and not asking them on day one to provide counseling, to have long treatment appointments, that we are seeing that person and reducing all the friction between them and medications. Next slide. So this is really around the real shift is to accept people where they are rather than making them prove readiness, and to think about all of the steps that we have in our current system where we are losing people, where people fall out, and reduce all of that friction. So what the open access clinic model is, it reduces that friction. We have smoother intake processes. We have navigators who help make that support, and we're able to meet people where they are. Next slide. So this is the core components. This is the system that we are hoping to build together. And that day one, medication starts now. We have flexibility in terms of patient goals, in scheduling. We focus on engagement and reentry. And so really thinking about how we make the low barrier model work. At California Bridge, we talk about these 3 pillars: low barrier access to medication, connection. So connection to your patients, connection to ongoing care. This is a key part of our navigator model. And then really a culture of harm reduction and a culture of reduced stigma, so that we bring all these pieces together and we reduce that friction and we make entry seamless, easy, and welcoming. And that is really how we are going to provide access to the 5 million Californians who don't have it currently, is by bringing these components, pulling them all together, and providing that welcoming, open access care to all of our patients. Next slide. Who makes the model work? This is really the most important part. Teams who work together lower that front door friction. And so really this is bringing your team together. As a prescriber, I actually think that I am the least important person on the team, because I am just the person who writes the prescription. All of the other people on the team, these are the keys that make it work, is the navigator who is providing that warm handoff that is addressing all of the pieces that need to come into place, logistics, they're building trust, they're helping to overcome a lot of the stigma that patients feel and experience as they're accessing care. And then our front staff, the folks who do the intake, vitals, scheduling, and really pull all the workflows together, these are the people who are really critical to making our system work. So each role here shortens the distance between the first contact and medications. And as much as we are shortening that distance, reducing the friction, making it easy for people, we're going to engage more patients in care and be able to keep them in transition to the next step in their care model. Next slide. This is my favorite part, because the navigators are really the key to providing low barrier care to people with substance use disorders. These are the folks that really hold our entire system together. And I cannot tell you enough what the navigators do in order to help keep folks into care. And when you think about navigator, we kind of really just think, oh, this is the person that helps schedule your appointment. No, this is the person that makes you feel welcome, that also helps to address barriers that we are not even seeing around. Can you get the medication from the pharmacy? Is it in stock? Will they provide it to you? Do you have transportation to get to the pharmacy? Do you have childcare? So all of these pieces, these external barriers that are placed between a patient and the medication they need, the navigators help reduce that friction. So we have friction that we have created within our own clinic, but then all of those other pieces in the community that need to come together in order for someone to be able to access treatment, that is what the navigators do. And I can't say enough about our navigator teams, but this is really the critical piece to help making your low barrier clinic work and work well. Next slide. So what about the navigator role? So this is really the key piece, is the navigator role and what they are doing in terms of making the practice work. They're doing outreach and trust building. And so this work happens before the person even comes in for care, in doing that outreach to make people understand that, hey, we do things differently at this clinic, and you will be welcome here, and you will be able to actually access care. So a lot of work is happening we don't even see. It's happening pre-care. It's that pre-care outreach, engagement, and trust building that is critical for the navigator role and critical for people to be able to access that low barrier treatment care through our clinics. Scheduling, reminders, And then really, as we mentioned, transportation, phone access, pharmacy access. These are the barriers that we hear over and over and over again that our navigators help to troubleshoot and to make work for patients. Next slide. And so this is kind of what this looks like, is that you have a walk-in entry point. This can be a walk-in clinic. This can be a referral from an emergency department, telehealth, in person. This is a seamless, the person walks in and there's a rapid assessment. What can we help you with today? Rather than a full assessment where someone needs to go through an entire ASAM assessment or talk about everything that has brought them to this point of what can we help you with today? What are your immediate needs and what are your goals? And so that we can do that rapid assessment and start medication as soon as the patient is ready for it. And if the patient is not ready for medications, we're still meeting them where they are and talking about harm reduction. So the key here is that we are rapidly addressing those patients' needs, meeting them where they are, moving them on to the next step, and making sure that we are leaving that door open for them to continue to engage our treatment network. And so really then the key is that handoff. So then again, we have sent out a prescription, we're not done. We got to make sure that the navigator reaches out with the pharmacy plan and a return plan so that they have closed that full loop. And then to know that people are going to mess up and that follow-up appointments are going to get dropped. And so what does our re-entry step look like? And how are we having that flexible follow-up around telehealth and how do we get people back in? So every step needs to reduce friction so that the patient can stay engaged and re-enter our clinic as quickly and easily and seamlessly as possible. Next step. So really this is the key, and really what I want to hone in on for our operational message is that we need reliable same-day pathways, so that's our clinic, a plan for pharmacy, and then a warm handoff so that we have all these key pieces, walk-in access, medications up front if that's what the patient is interested in, easy re-entry, and just to make sure that we are flexible in terms of how we are approaching patients' needs. Next slide. Telehealth. We love telehealth. Telehealth just lowers friction between touches. So if you are not integrating telehealth, now is the time to do it. Telehealth really expands access, expands your reach, and really expands the number of people and how they're able to access care through your clinic. So these are some of the things to talk about is like, how can you quickly schedule and implement your telehealth? Think about the platform that you're used. Are you accessible with phone call only? Because some people are not able to access video capability reliably. So can you have a phone only telehealth version? How are you handling pharmacy issues real time? And so telehealth really helps to lower friction and lower barrier. So this piece here, if you haven't implemented it, will go a long way to making your clinic an open access clinic. Next slide. Open access, a lot of times we think of primary care and it's sort of the antithesis of open access because the traditional scheduling model, we have scheduled out appointments. But what we really want you to think about is this works well and beautifully in primary care. The trick is really just that flexible scheduling and allowing time and space for walk-ins. And so what happens often is those walk-in appointments are added on to an already busy practice, but keeping space in that schedule in order to accommodate the inevitable walk-ins. So basically you open up the schedule and you know that you're going to receive walk-ins, and making sure that you are incorporating that can be scary, but does work. And so just changing that mindset to incorporate space into the primary care practice to allow walk-ins. Next slide. And the benefits of open access, particularly for this patient population, really increases initiation, increases retention, and then what we see reduces mortality, healthcare costs, increased quality of life. And really, this is the key, is how do we meet all of the people who are not currently accessing care? And so there's huge benefits both to our clinics as well as the people that we're providing care to. Next slide. And as we go on currently, we're going to talk about some of the challenges. I know there's a lot of stigma, there's fear. We're worried about our productivity, how we incorporate telehealth and flexible scheduling, and we're going to talk all about that in our later slides. Next slide. But I'm going to turn it over to Greg to talk about the full spectrum of open access clinic models.
Excellent. Thank you, Amy. So yes, we will talk about where these open access clinic models can sit inside the ecosystem. If we can go to the next slide. Emergency rooms are a place to get same-day low threshold access. They, however, are not the clinic model per se. This is a place that is foundational to making sure that there is access that is both same day or same moment. You have that 24/7 availability, and this foundation needs to be interconnected and overlapping with the other components. And those are the organized delivery system, the drug Medi-Cal. So your substance use treatment disorder locales, the opioid treatment program, the outpatient programs, both residential and intensive, places where the emergency room can coordinate with and can create their own low threshold access, both for initial and follow-up care. And then many of you, I think it was close to 50% on the poll there, were saying that FQHCs and primary care in your county are places where there is open access for substance use treatment. So a key part of it. And the connection of the ecosystem together to be able to activate kind of real-time access, not just through these clinics, but through navigators and other components of the ecosystem to make it real, to make that access real for patients that are seeking treatment. If we can go to the next slide, we have a kind of visual of the ecosystem, a person at the center, as they should be, and potential places where they could be identified and initiate treatment. So that could be anywhere from the hospital setting itself. That's obviously not an open access clinic, but it's part of the total ecosystem. It needs to be connected to the whole in giving that easy, welcoming access for initiating treatment. Emergency room, we talked about, as the foundation. Primary care, both as a place where there is scheduling and resources set aside for easy access, and community health center outreach. So population health resources to identify and keep connected to patients that are either in treatment or may need treatment. And then the substance use treatment providers who are accepting referrals, but also a place for initiating treatment. Community-based organizations could be harm reduction, focus, education, other community-based organizations who may be the first contact and can help create that welcoming environment and create a situation where someone is interested in care to one that is true open access and they're connected with that care. Public health, of course, and homeless service providers really is one of those community-based organizations that may see more and have more opportunities to connect with the rest of the ecosystem. And then, of course, the justice system is another place where it's important to have systems set up for easy and quick access to treatment initiation and ongoing treatment.
We're going to talk next about how do we know if we're succeeding? What are our goals and how are we going to measure success? So we're making these changes, we're adjusting our scheduling practices, we're bringing in more navigator staff, and how are we going to know if what we're doing is working and meeting the needs of our community? So we're going to talk about some metrics out there that we can use both to communicate our success to stakeholders like the state of California and our health plans, but also to make sure that we're meeting our needs of our population. Next slide. And so really we want to think about ways that we are meeting all of these pieces. It's not just about starts. We want more people to have access. We want to start more medications. We want better handoffs, and we want more reliable return pathways. So we're going to talk about these 4 pieces: access, medication starts, linkage so that we're able to get to the next step, and then retention. How well are we able to keep people in care once we've gotten them there? And so these are the 4 pieces that we're going to be talking about, that we're trying to achieve these 4 pieces. Next slide. And so we're going to talk about metrics that are already out there. One of the key pieces is follow-up after an ED visit for substance use disorders. This is a critical goal for Medi-Cal, is to improve that follow-up, and they want to improve it by 50%. Seems like a lot, but fortunately our baseline rates are so dismally low that that 50% is achievable for us. But also there are financial incentives for plans to make sure that people are connected after they leave the emergency department. So this is an opportunity for us both to be able to see if we're providing that low barrier follow-up after the ED visit through our low barrier access care, but also to leverage some of those incentives through the managed care plans. Next slide. This is not the only measure out there. So there are other HEDIS measures that we're going to talk about. And remember, HEDIS measures, these are the scorecards that plans are measured on. So these are kind of the standardized quality metrics. And what we're trying to do here is to show whether people are actually getting identified, treated, and connected to follow-up care. We want to know if the services are working, not just that they're available. So 1, people who are diagnosed with a substance use disorder. We can't fix what we don't know is out there. And so this is increasing the number of people who are screened and diagnosed and recognized with the substance use disorder. And one of the key pieces here is this starts at 13, because we know that addiction is a pediatric disease. And so recognizing that we need to reach those younger folks, 13 and up, to make sure that we are identifying people who are at risk at younger ages, and then again throughout the age spectrum. Number 2 is about opioid use disorder. Are we giving medications to people with opioid use disorder? We know that medications work. We know that they are integral to treatment and recovery. And how well are we doing at getting medications, pharmacotherapy to people with opioid use disorder? This one is 16 and up, because 16 and up in the state of California are eligible to receive medications without parental consent. So that's an easier population to include in our metric. And this is about, are we getting them on medication, and can we keep them on medication for 6 months? This is really key. And then number 3 is that follow-up after an ED visit. And this is really around, are we having that low barrier access? So are people being diagnosed, are being treated with medications, and do they have low barrier access and then re-access re-entry points? So these are 3 key performance measures that the health plans are being measured on. And so we can use these to see how well our low barrier clinic is working, but also to sort of leverage that partnership with our managed care plans, because they are important to them as well. Next slide. We're going to talk more about follow-up after the ED visit. Why is this important? Mostly because we're doing a pretty poor job. Because we find that most people who visit an emergency department who are diagnosed with a substance use disorder are not receiving follow-up at 7 and 30 days. And these are key performance benchmarks because these are folks who we know need follow-up at a minimum. People who have substance use disorders, who are also having consequences of their substance use disorder, experiencing withdrawal, overdose, complications. So the highest risk patient population are the ones that we really need to focus on making sure that they have low barrier access. Next slide. I also know this is hard, right? We know that it's hard to provide access to people who are not currently accessing the system. So folks who are seeking care in the emergency department often have barriers to accessing outpatient care. And so at a baseline, it's a challenging population. But good for us, these numbers are low. 7-day follow-up, 18.4%. We can do better. 30-day follow-up, 28.6%, we can do better. So the good news for us is that currently we're doing a really bad job of providing follow-up. And so we can do a whole lot better by opening up our schedules, making our clinics welcoming, having that open access, and we can make these numbers better. And so we can see like this is the key gap is that people don't have access to treatments and that we're not even getting the most high risk individuals into outpatient treatment. So we can do better, lots of room for improvement here. We are setting the bar low for ourselves. Next slide. This is kind of the fun part is like, right, when small changes make a big difference. This is another metric that I want to talk about, the initiation and engagement in substance use disorder treatment. So this is looking at, again, 13 and up, people who are newly diagnosed with a substance use disorder. So you've initiated screening, you identify someone who has problematic substance use or a substance use disorder. Now what? So this is around, you've identified people and there are two pieces. Initiation, so you are initiating treatment within the first 2 weeks of that new diagnosis, and then you're continuing to follow them. So they have another 2 visits after their initial visit. And so this is really important measure to see how well we're getting folks into care and then keeping them there. So this is really important metric. It is different than the follow-up metric because one, it is looking at people who are seen outside of the emergency department. So this is our population that we are screening, that we are diagnosing, that we are recognizing has a substance use disorder. Are we providing the follow-up care that will help get them to recovery and keep them in care? Next slide. And again, this is around our initiation and engagement rates. This one, I feel like, again, lots of opportunity for improvement here. So 37% of people that we recognize with the substance use disorder, we saw again within 2 weeks. 37%, we can do a lot better here. And then of those people, of that 37%, how many did we get to see again within 30 days? 13. Next slide. So you can see we're losing a lot of people here. People are really just falling out of our system in high volume. So let's talk about this. So we have people who are diagnosed with the substance use disorder, right? So then 63% fall out just in getting to the next clinic appointment within 2 weeks. And then if we look out for 30 days, we want another 2 visits there. 87% of the people are falling out. So we're just losing people in every single one of these steps. A low barrier access clinic could directly address these gaps. So a low barrier access clinic could offer same day, next day starts, walk-in access, and reducing that friction between identification and engagement and being able to be flexible in our scheduling and having that open access clinic will go a long way into moving some of these numbers. We get a lot of room for improvement. So I think we can do a whole lot better here. Next slide. I'm going to turn it back over to Greg to talk about how you can implement this in your community.
All right, thank you, Amy. So we're going to talk about some ideas for, or frameworks for starting and implementing open access. All right, we can go to the next slide. Um, so when you're looking at and making a roadmap of how would my system or my clinic or my county implement an open access um, clinic or site, you want to start with thinking about the principles that Amy went over, that it's low barrier, that it is open access. That's what you're trying to create, that it's welcoming, that it's coordinated and connected to the ecosystem and set up your goals, right? So we saw from Amy that we're far from reaching the kind of outcomes we want to see. So set up some specific goals and then make your roadmap. And your roadmap is going to generally be looking at if you're starting a open access site or clinic, it's going to be starting by looking at your entry point. Where and how are people that are ready for treatment going to access this uh, entry point that you are setting up. So decide where that will first happen and then map the workflow. So that starting point may be, an FQHC and walking up to the front desk. It may be a navigator in the community and how they connect with another entry site or a place where care will happen. So map the workflow right from navigation to what the schedule looks like and how uh, the person who enters care through that open access will be tracked for their follow-up. Building a referral list, both for referring patients in and referring out to partners. So this could be if there's an entry point and you're imagining the entry point being the emergency room, that the emergency room is able to refer to primary care, community health centers that have open access scheduling that will allow the person who has entered care in the emergency room to then have open access the next day. And then backup options for each one of these. If we can go to the next slide. Um, Important in your plan for developing open access is not only having the schedule and being able to visit with the provider and the care team, but also to have a pharmacy plan that they're actually able to be able to get the medication um, uh, filled, dispensed, and be able to use it in an open access same day way as well. And then a plan for training your team, which may cross over organizations. So, from that navigation and referral in to the place of care, everyone on that um, reducing stigma environment and being able to respond to the needs of the patients and provide that rapid either entry to care or reentry if it's a follow-up and harm reduction kind of weaved in throughout. And then measure and iterate. This will not be perfect. You shouldn't wait to start and put in place a open access um, uh, new entry point and another place where people can get care in an open access way. So it won't be perfect on the first time, and you shouldn't expect it to be. You don't need to build it to be, but have your principles, map out that workflow, initiate it, and look to see where there are problems, either low return rates or not enough patients that didn't meet your goals, and so you're setting up more incoming referrals and connecting with other parts of the ecosystem. So iterate and use your data to iterate on that. Next slide. Some policy and funding levers when we're thinking about sustainability. So strategies for implementing, yes, but once you're implementing, you have to ensure that the thing you're implementing is going to be able to be sustained over time. A good part of that is having the workforce, as Amy said, those navigators who could be community health workers are key to creating the ecosystem that really creates a environment that is not only open access from the view of a primary care provider or a substance use disorder provider having a schedule slot and some resources open. It's more than that. It's the whole ecosystem so that people can get into care on that same day in a way that's aligned with what they need. And then, of course, reimbursement. So ensuring that there's reimbursements for all components of the model you're implementing and supporting the reimbursement of that over time. Counties generally have all of these ingredients, everything that we've talked about, with a significant challenge being stitching those together and creating that ecosystem for all of the parts. And we can go to the next slide. And this is just thinking at a county level about policy and funding levers to make this more durable. One is writing expectations into contracts that one of the requirements for reimbursement and funding is to have low barrier access, both for initiation and returning to care, and that there's data. So those outcomes that Amy talked about are looked at, and there's expectations that the way the program is put in place will move those metrics. So data and accountability for tracking that treatment and engaging beyond that first visit. And the next slide. So when you're considering implementing low barrier care, open access, whether this be in a primary care environment or other environment, really culture envelops it all. So it's important to work on culture, to realize you're inside a system of care. So working on the system, and then the actual service delivery, which is sometimes where we start. But you want to create a culture that is prepared for the substance use disorder treatment environment, reducing stigma, getting out of what is a traditional primary care office mindset of making sure that the waiting room is full and that schedules are full a week or two out so that you're ensuring that the providers are always busy. That will always be a reality, but inside of kind of open access, low barrier care, you've got to say, okay, that's our usual, but we need this other type of culture for substance use disorder treatment, and recognizing and working through waiting room culture concerns, where often in primary care setting, there's concerns about having, families and with the substance use disorder population, and that needs to be worked through and understood. And then the systems, of course, are the kind of county behavioral health environment and your managed care plans, the insurance environment, CFR 42 always coming up in terms of having consent for the sharing of information, and knowing what your environment is for having ECM and community health workers being part of the ecosystem. Service delivery is what we talked about, those parts to get down to really implementing open access and making it real. We'll go to the next slide. And this is just looking at urgent care and harm reduction sites as potential entry sites for care, and why it works. Urgent care, obviously, there's no appointments necessary. It is set up for this kind of same day and low entry. You just have to make sure that there is a coordinated way to have continuity of care subsequent to that, and that the MAT training is in place. And in the harm reduction sites, you have a trusted environment. You can certainly start your buprenorphine. The challenge is in the funding and in documentation and billing for the services in that environment.
Thank you all so much for viewing today's webinar. If you have any questions, please feel free to email us at info@afbsstraining.org. Thank you and have a wonderful day.